we have Dr. Matthew Johnson, PhD. He is a professor of psychiatry at Johns Hopkins University and associate director of the Center for Psychedelic and Consciousness Research. He's been, it's probably hard to find somebody who's been doing work, such central work with psychedelics for so long. Since 2004, he's been researching psychedelics and publishing work on it, and really with an enormous range. So ranging from the very close up, personally guiding sessions with participants in these clinical trials to the most very far out, zoomed out epidemiological studies of how psychedelic use affects behavior and public health outcomes. Also creating and then validating the scales we're using to measure psychedelic experiences, commenting on the legal aspects, et cetera, et cetera. You know, and not only is he an expert on psychedelics, but many other psychoactive substances, ranging from caffeine and nicotine to salvinorin A. And I love this energy drinks and Remeltion, which I learned about, which is a melatonin agonist for sleep. But I'll end by just saying that, you know, the pioneering work that stood out to me is his work with smoking cessation. The work with addiction is my favorite work in the psychedelic research realm. Again, with all this, the question about placebo and what's happening, you know, at the end of the day, a person is or is not smoking a cigarette, or is not addicted to a substance. We don't really care how they got there, but we can see the effect. It's visible, it's profound, and it's really cool to see. So thank you so much, Matt, for coming, and I'll hand it over to you.
Yeah, thanks, Gianni. I really appreciate that that generous and comprehensive introduction. And yeah, one way to put the Remeltion work, the melatonin agonist, is like, no matter how much you give of the stuff to people, you just can't get them high. Like that was, you know, 16 times the therapy, like melatonin itself. Yeah, and
different story than the psychedelics.
Different story than the psychedelics, for sure. And yeah, I appreciate your comments on the value of looking at addiction as a behavioral outcome. And so that's really the heart of why I wanted to push this work in the addiction area, because I am interested in mystical experience, which I'll tell you about, and these other, you know, transcendental states and all of this. It's, you know, but at the end of the day, I'm trained, and I'm still like, you know, the behavioral lens. I'm trained as a behaviorist, and that's my primary scientific lens that I see things through. And hey, that's where the rubber meets the road. And so if this is really worth its salt, then you should be able to push around some behavior. And what better test than trying to change an addiction. So I'll go ahead and share my screen, and I'll, again, apologies for leaving you folks hanging. But I'll try to get into, try to make up for time and cover the interesting stuff. So first, just want to disclose I do have some advisory relationships regarding some organizations developing psychedelics or related compounds as medications through an FDA pathway. So I'm going to be talking obviously about psychedelics, but no work specifically to those entities. So we probably
Matt, we're looking at your presenter view.
Presenter view. Let's see.
Give subtitles a try.
Give subtitles a try. Doesn't go away.
Let's see.
So you may want to escape out of this. I don't know. I would just escape this screen and then reshare your screen, but just pick the.
Yeah. Thanks for.
No problem. If there are questions for Matt, put them in the chat, and Gianni, I think you can moderate.
So you're.
Yep.
You're still seeing the slide.
Still seeing presenter view.
Yeah, the presenter view. Well, let's see. Let me stop sharing, and then.
There was a spot that said display setting.
I think this is probably going to work. How's that?
Bravo.
There it is.
Okay, cool.
And also
Alright.
just, Matt, no need to rush for our sake. I know it's late for you, but do your thing.
Okay. So if you don't have a hard stop, so that's great. So I'm going to be talking really all about psilocybin as a focus, and so that's the active agent in over 200 species of mushrooms, mostly in the Psilocybe genus, and some other genera of mushrooms. It's a classic psychedelic, puts it in the same category as LSD, mescaline, and dimethyltryptamine. So these form a pharmacological class, and they are distinct from other drugs, sometimes called psychedelic or hallucinogen, like MDMA, which is a serotonin releaser, or ketamine or PCP, dextromethorphan, which are NMDA antagonists, or salvinorin A, which is a kappa agonist, and others. And ibogaine, which kind of does everything under the sun pharmacologically. But mostly what I say about psilocybin is going to likely be true for these other ones. Of course, like the studies of efficacy would need to be repeated with all of these drugs in particular, but decent bet that a lot of what you see with one, you're going to see with the others. And we know that serotonin 2A is the primary site of action for a number of reasons. One, these drugs produce very reliable discriminative stimulus effects in non-humans. For those who aren't familiar with that, it's essentially a way through operant conditioning you can train a rodent or another animal to reliably tell you essentially whether it's received a particular drug or a saline injection. And then you can do things like swap out similar drugs and see how they respond, and that tells you a lot, in terms of whether the animal essentially whether it feels similar to another drug. And one of the other things you can do is you can throw in an antagonist that blocks that a particular receptor, like the 2A receptor, and sure enough, you see that antagonist at the serotonin 2A site will block the discriminative stimulus effects of these compounds. You'll also see that antagonist in humans at the 2A receptor will block just the subjective effects under double-blind conditions. And another piece of evidence is that the 2A, that affinity, or essentially the stickiness for the receptor at the 2A site is remarkably well correlated with the potency in humans across compounds. And by potency, I mean the strict pharmacological definition, essentially how small can the mass or the weight of the dose be and still have a defined threshold effect. And I'm just showing you that first published tight correlation that Richard Glennon published in '84 with 2A affinity plotted against the human hallucinogenic dose across a wide variety of compounds. These drugs, staying on the pharmacology, non-human pharmacology, one of the remarkable things about this drug class in general is that they don't appear to be addictive or result in compulsive drug seeking. And they one of the ways to examine this is at operant self-administration models in non-humans, which are pretty reliably related to addiction potential in humans. And the best attempt to get these to serve as reinforcers or to be self-administered was likely done in this study by Bill Fanagrossi and colleagues in 2004. And they did a number of things, kind of jumped through a bunch of hoops, like initially had them on an MDMA baseline, which is kind of like in some sense a fading procedure, because MDMA also has some dopaminergic effect, and it has a stimulant-like profile, some similarities to the very reinforcing stimulant. So sort of halfway in a sense between the stimulants that are reliably self-administered and the classic psychedelics. And sort of off that baseline, they got a little bit of reinforcement, not much, basically some transient levels of reinforcement in only a subset of animals, but that that was temporary. So rates above saline. What I'm showing you here is on average across animals. You got rates that were below the self-injection rates for saline, which is denoted by the horizontal line at about 8 on the y-axis here. So, that's true for DMT and psilocybin. So there's an absolutely ancient history and prehistory of use of psilocybin mushrooms. We see artifacts in the left and in the center panels suggesting sacramental use in Mesoamerica and South America, dating back from several hundred to 1,000 or 2,000 years ago. If you go to the old world, you see even more ancient use. On the right, I'm showing you a cave painting from Northern Africa, Algeria, suggestive of sacramental use dating back to around 9,000 years ago. So that's several thousand years before the first human civilizations popped up in Mesopotamia. So that's the prehistorical part. And it's not 100% definitive, but it looks like, those little guys dancing around and their heads have been turned into big old mushrooms. And yeah, I would say at least suggestive of use of these mushrooms, combined with the environmental evidence and that although they don't grow there now, that the environment would have supported them and they likely grew there at that time point. Fast forward some millennia to the 1940s through the 70s, psychedelics were intensely investigated as research tools and therapeutics. Really a lot of interest in the basic research findings. Just astonishment at how potent LSD was, the mental effects that were achieved at as little as 1/10 of a milligram. And this was around the time when it was discovered that serotonin wasn't just this chemical that showed up in the gut, but it was showing up in the brain. And lo and behold, there was a structural similarity between serotonin and LSD. Combine that with this observed incredible effect of these minuscule amounts to have these profound effects on mental function. And it was a real clue, and one of the pieces that emerged that really led to, and it wasn't the only thing, but it was one of the important pieces of really a modern neuroscientific understanding of the brain as an electrochemical messaging machine. And so that, and then there was explorations of essentially modeling psychosis, and hypotheses surrounding the idea that maybe psychotic disorders like schizophrenia were caused by an endogenous compound similar to LSD. That line didn't really turn out to lead anywhere, but nonetheless it led to a lot of investigation regarding psychotic disorders. But then there were also the therapeutic studies, so using primarily LSD to study the treatment, to try to treat a couple of things that were the most promising was cancer-related distress. So these were largely terminal cancer patients that had substantial anxiety about their death, and also using LSD to treat alcoholism. It was really, LSD that prompted this interest in the 1940s. It was its synthesis in the late 30s and the discovery of its psychoactive effects in the early 40s. It was really that potency that really started the excitement, and probably also the fact that it was Sandoz Pharmaceutical, which is now Novartis, they were willing to send us basically around the planet to anyone who said they were interested in doing research, with a pretty low threshold for what constituted research, because they were looking for a use for this drug that they had the rights to at the time. And mescaline had been discovered around the turn of the century, a little bit before 1900, and a little bit of research on that, but it really didn't. It was really didn't move the needle that much. It was really LSD that started the interest in earnest. So after that heyday, sort of moving into the late 60s, early 70s, you went from this early age of enlightenment in terms of research with these compounds to the dark ages. So despite some early preliminary promising therapeutic findings, you entered these decades of dormancy. And this was a reaction to the very real casualties that were showing up into emergency departments, and but also to the sensationalism. But, when I should say that the doses of LSD on the street were about 6 times higher than those on average these days that show up in seized samples. And yeah, there, as I'll go into when I describe some risks, it shouldn't be surprised. There were certainly some real casualties when LSD became popular, very popular in the late 60s. But then it was really the combination of that with the sensationalism from the media and failure to distinguish between, cautious clinical work and just, the recreational use. Very different risk profile. And that's going to be true of any compound. Morphine used if you've fractured your femur or your hip in a automobile accident, for example, versus like, the people nodding out on heroin at the bus stops in Baltimore that you could see any day driving past, like, virtually the same pharmacology, but vastly different risk benefit profile. And tied to that was just a small minority of researchers were on the reckless side. And unfortunately that, kind of led to this, the idea that, oh, you can't even trust this stuff, so powerful, you can't even trust the researchers. And in fact, that wasn't a fair assessment, because most of the credible researchers in the area, like Sidney Cohen and Humphrey Osmond and Abram Hoffer, were begging folks like Tim Leary to tone it down and to be more clear about the risks and not to encourage rampant use. So, after those dark ages, we're now entering a new age of enlightenment, at least in terms of the research. I'm plotting the PubMed hits for psychedelic or hallucinogen showing up in the title of papers, going back to the 80s with a fairly steady baseline of 5 to 20 papers a year. And then you could see this just incredible surge in the early 2000s. And that seems to be a continuing exponential-like trend. I said I'd mention the risks. Won't spend too much time on this. There's a lot to talk about, but basically the major categories, and this is true for any of the classic psychedelics, it seems pretty clear from clinical observation that people with psychotic disorders and perhaps bipolar, that they can, or a predisposition for those disorders, that they can be destabilized by experience with these compounds. The urban legends of people that tripped and never came back, I mean, that's clearly an overstatement. The pharmacology, the drug is metabolized, but nonetheless, I think, clinically, this is really, very similar to what, what we know about, people with this predisposition or active disease. Like, they can be destabilized the same way an unstable life circumstance can destabilize people. A traumatic experience can destabilize and worsen or precipitate the first break or destabilize an active disease. So, there's that. And then for anyone, any healthy person, especially if the dose is high enough, there's the bad trip, so it's panic, confusion. And while I don't want to overstate it, usually people that use these in, non-supervised conditions, usually people are fine. But, usually when people don't wear their seatbelts in a car, usually they're fine too, so you look at the numbers and there's clearly a signal. Sometimes, again, rare, but it's very real. People engage in dangerous behavior. They run into traffic, they fall from a height. Probably too much was made in the late 60s and the government propaganda about jumping from heights. There have been some cases that it's always hard to tell what was going through the mind of someone who, fell to their death, but there were some cases that have looked over the years that where the person may have thought they could fly. Probably most of the cases, it's just someone being very intoxicated. We know plenty of people die every year falling from heights, being impaired on high doses of alcohol, and these are highly intoxicating drugs at high doses, so it should be no surprise. And then other things like some modest cardiovascular response, blood pressure and pulse, that could be, for those that a severe heart disease, that could be a problem. Something we've documented, headaches in the day following use, typically mild to moderate, something that wouldn't prevent its medical use. Very rare disorder called, it's in the DSM, hallucinogen persisting perceptual disorder. Extremely rare, never seen in the thousands of people that have taken these drugs in the earlier era or the modern era of clinical research. And in the limited information in the scientific literature, I think one of the strongest clues is the fact that you actually see this disorder or something that looks like it pop up instigated by the use of any number of drugs, including alcohol, benzodiazepines, cannabis, and tobacco. It may have been historically that it was just sort of kind of related to like the psychology of xenophobia or something, like always the other, the strange thing gets the, gets the causal attribution when something, wildly negative happens. And so it may be that that in this sort of rare neurological susceptibility that we don't understand, that any number of drugs precipitates that. Nonetheless, since there is something of a signal, there is something we should continue to always look at, both in, I think, in the research and potential, after potential approval and clinical use, to keep the radar screen up to understand more about that and try to minimize it if it starts showing up. And then I've already alluded to this, but one risk domain worth mentioning is that they don't appear to be drugs of addiction. Now, this is atypical for drugs of abuse, and clearly these are drugs of abuse, meaning, they can be used in ways that are harmful to the self or to others. There's plenty of examples of those types of patterns, but they don't lend themselves to compulsive drug seeking, self-control problems. I've never really come across a credible even example. The only cases of people getting into, daily use patterns, it's more typically like, someone doing it like on a dare, like, to see if they could take mushrooms or acid like every day for a week in a row. It's not like that person is like jonesing and, tells himself they've got to quit, but they feel compelled to keep seeking it out. You just don't see credible cases like that. And that's consistent with the way we know it. There's not the classic response in the mesolimbic dopamine pathway, and it doesn't show up in the large scale epidemiology, especially if you make sure you're not letting MDMA and PCP slip in, which again are of a different pharmacology, and not all of the surveys separate those out. But when you do, you don't really see addiction showing up at credible levels. So I'll go into some of our research findings now. Just briefly about our combining some of our initial healthy normal studies, so people without a disorder to treat. One of our an interesting finding was that in combining the data from our first two healthy normal studies, we found that psilocybin administration resulted in an increase in personality openness. So this is the personality domain of openness to experience. It was measured by the Neo Personality Inventory, and this domain refers to appreciation for a tolerance towards other people's points of view, the ability to hold seemingly mutually exclusive viewpoints at the same time, thinking of more of a both and rather than either or framework, and an appreciation for aesthetics. And so this is, quite remarkable to my knowledge. This was the first example ever of a relatively discrete clinical intervention, like a laboratory-based event, something you could schedule for next Wednesday, for example, for it to change a validated personality construct. I mean, the definition of personality is it right? It's a trait, like it doesn't change. And there's certain things we know that over the decades of a lifespan, there are trends for its change. In fact, one of the trends is for its for openness to decrease with age. and or life events like marriage or having kids, but again, nothing like an experimental manipulation to change. And now that's been replicated by other labs at this point with psilocybin and LSD. So it seems to be a robust finding. And it wasn't just receiving the psilocybin. So it depended on whether one had a so-called mystical experience or not, a complete mystical experience. It sounds woo-woo. I'll explain a little bit more about that. It's a concept that goes back to William James, the founder of American psychology. And it's even though it sounds a little woo-woo, it's nominally divorced from any supernatural or religious belief. So it describes a subjective experience. And James and others were fascinated by the descriptions of extraordinary experiences outside of drug use, across cultures, across the centuries, from written and described in different languages, and the commonalities, and prompted by different things like either fasting or prayer, or sometimes out of the blue. But what describes the experience is having an overall sense of unity, and can be expressed different ways, such as feeling at one with the universe or one with the rest of humanity. Overall positive mood, a transcendence of time and space, like stepping outside of the bounds of time and space, like they have less or no meaning. And then a sense of ineffability, that the experience was beyond words. And so we've found time and time again that that's been a meaningful construct to measure, that shows some relationship to the results. And I'll continue to show you some more of those results. And I'll say that the existing scales had been ones that were really designed originally to measure these experiences across the lifespan. We developed a scale, and those are the ones we originally used, but we developed a scale called the MEQ30 based on previous scales, and we validated it for use in a relatively discrete setting, like whether this event in totality happens on a given occasion, like with drug administration or another acute manipulation. You could use it, for example, in a meditation treat or some other thing like that, like an isolation tank. You could apply it. So I'll move into some of our therapeutic work. So the cancer distress work, picking up on that older LSD work. These are 51 patients with life-threatening cancer. About a third met criteria for a DSM disorder associated with depressive symptoms. A third met criteria for a disorder associated with anxiety, and about a third met criteria for a disorder of both types. It was a crossover design within subjects, so everyone basically got the real deal high dose, and in another session, a trivial dose. So everyone got the high and everyone got the low trivial dose. And they were just randomized in terms of whether they got high first, low second, or vice versa. And so we followed up in between those sessions at 5 weeks to assess symptoms. And then we also had a 6-month follow-up. So I'm showing you two of our outcomes here, the Hamilton Depression Inventory and Hamilton Anxiety Inventory. These are clinician administered scales. Both randomized groups came in at very high levels. So this is the clinically severe end of the scale and into the 20s. And it's before anything differed between the groups. So it's good that you see that they came in at about, on average, the same levels. But then the groups that randomized to receive the high dose first, the red group, post one shows 5 weeks after that first psilocybin session. So now the red group has gotten the real deal. You see substantial reductions into the range of the scale that's not indicative on average of any clinical problem. You see also some substantial reductions in the low dose group, however, not nearly as large, but those reductions probably due to both the preparation. There was 8 hours of preparation for these sessions, including discussion of the person's cancer, and that no doubt had some benefit. in addition to the what is called placebo effect or expectancy effects. And then you at post 2, that was 5 weeks after the second psilocybin session. So now everyone's had the real deal, whether it was 5 weeks ago or 10 weeks ago. And so now you see both groups down to that very low level of symptom reduction. And then virtually identical results at 6 months, which is really, it's kind of unheard of for typically to see, reductions from one drug administration to last 5 weeks later. So much less 6 months later. So that's a remarkable finding, and the results for depression and anxiety were virtually identical. And then we found that the reduction in anxiety and depression 5 weeks later was statistically related to how mystical their experience was, their subjective experience was, as measured on the day of their session. So after the drug wears off and before they go home, this is measured. And and that held up even after statistically controlling for ratings of how intense the drug effect was. So there seems to be something about the nature of the psychological experience that seems to be important here. So it's not just in our hands. Our good colleagues at New York University finished their study around the same time, and we published it in the same journal issue. So they had 29 patients, very similar, also a crossover study, but they used a different active control. Instead of a low dose, they used niacin. And so some differences, but nonetheless also found very large effect size reductions in depression and anxiety. So really speaks to the robustness of the effect to be seen in a differing design. And I should say at about half the dose, both of these studies followed up our colleague Charlie Grobe at UCLA, finding in a smaller study that she showed evidence of reductions in anxiety and depression in cancer patients. So now moving outside of cancer into just major depressive disorder, the first work in this area was published by the Imperial College Group, and in an open label study found long-term reductions in depression with open label psilocybin. We recently, I guess a couple months ago now, published in JAMA Psychiatry the first randomized trial. It's sort of an entry-level randomized trial because it was a waitlist control. So it's open label still, but people were randomized to have their 2 psilocybin sessions either more immediately, but still after the preparation sessions, or after waiting several weeks. And what you got was people that were randomized to get the immediate treatment saw symptom reduction after their treatment with the psilocybin sessions. And during that time, you did not see any change on average in the delayed treatment group. And what I'm not showing you here is that after that group was crossed over, so the delayed treatment group then had a chance to have they actually received the treatment. And then when they did, they saw a nearly identical size level of reduction that the immediate group saw when they first received it. So expected results, and of that similar very large effect size that the Imperial College colleagues had seen in their paper. So now moving on to addiction. So this was inspired by the earlier work in the 60s with and early 70s using LSD to treat alcoholism. And so reviews described this as sort of a mixed bag. Some studies showed a significant improvement with LSD, others didn't. But this meta-analysis provided an important lens. So back in 2012, it was found that I'm showing you the results here, at least on one of the metrics, that the odds of improvement at the first follow-up and the timing of that follow-up differed across studies. But you can see the 6 individual dots with error bars around them. Anything to the right of the line showed that the LSD group did better than the randomized comparison conditions. So there were only 6 studies that randomized, a lot more studies that examined the basic topic, but only 6 randomized people to either LSD or some comparison condition. And so every single one of them found at least a trend suggesting LSD improvement. You could see the LSD was better. You could see with the error bars that some were not significant. They crossed the odds ratio of 1. Odds ratio of 1 would suggest equal likelihood of improvement across the 2 conditions, so no effect. But you can see that the trend was always in that direction, sometimes significant, sometimes not. And then in the aggregate, you see with the big fat diamond at the bottom, that's the aggregate across the different studies. And that was both statistically significant, but more in the direction of LSD, obviously, but more importantly, just the effect size. It was an odds ratio of about 2, which means essentially the folks receiving LSD had nearly double the odds of improvement compared to the other conditions. And then there was one study treating alcoholism conducted here in Baltimore, and for the day, it was pretty impressive. They had biological verification with urine collection, verification of abstinence from heroin, and there were some limitations. So the LSD group got some inpatient treatment that the other group didn't get. So, but they acknowledged these and called for follow-up work, which never happened because this was right at the end where the rug was being pulled out from the research and the funding was gone, and really more importantly, the professional marginalization. It became like really out of fashion, to put it lightly, to do LSD research. And it was like night and day compared to like 5 years before that, where it was like cutting edge psychiatry. So unfortunately there wasn't that follow-up, but there was a signal of just a substantially better outcomes with using LSD compared to the control group to treat heroin addiction. So with that potential, that combined with a bunch of anecdotes for even other drugs, people overcoming other addictions, cocaine, etc. It looked like there was this potential anti-addiction efficacy that worked across different substances of abuse. So I decided to look at smoking cessation. It's something that I had experienced conducting smoking, tobacco research going back to my beginnings of graduate school. So it's also very quantifiable. It's a great model system for addiction. You can easily biologically verify abstinence, and everyone knows basically how much they smoke. It's a little easier to quantify than other drugs. Besides that, it's like also, besides being a good model system, it just like kills far more people than all other drugs combined. I mean, 4 times more than alcohol. And when you put it on the same, graph, like the illegal drugs like barely show up like visually compared to the deaths. 500,000 a year about die in the US alone died from smoking. So we had the funding for just a pilot feasibility study. We wanted to test the waters and frankly didn't have money for anything more substantial. Yeah, I'm showing you here we're happy to get, media attention. I wish the media covered science in general more than they do. But I have to say something I've learned is that, you don't always control the coverage, so this is an example. Hopefully it's clear by now. I'm not encouraging anyone to use psychedelics. They do have risks, and, I'm not responsible for, what people do, but I'm certainly not encouraging their use. But I do want to put extra emphasis on this. Don't do that many mushrooms, because that's just crazy. They didn't run that picture past me. So the pilot study, the demographics, the only thing important here is that they were like pack-a-day smokers, had been smoking on average 30 years. Like, these were not lightweights. And it was a 15-week protocol. We combined it with cognitive behavioral therapy, which is the most typical type of talk therapy, helping people quit smoking. Basic stuff like keeping a smoking diary, putting down your thoughts, feelings, what's happening in the environment when you do smoke before you quit. You assign a target quit date, so you don't just quit on the fly, but several weeks ahead of time. You keep your eyes on the prize with the target, a set date where you're going to quit. And you prepare them like, if you do slip and you have one, this is how you handle it. You don't dwell on guilt, things like this. So that's all cognitive behavioral therapy. We had 3 psilocybin sessions over an 8-week period, ranging from a moderate to a high dose. The first psilocybin session was on their target quit date. This is one of our 2 biological metrics, carbon monoxide, and these were on the x-axis are the various meetings. So this was before their first psilocybin session. This is after. Clearly, you see a pre-post difference here, and what that means in terms of point prevalence, a typical way to measure smoking, meaning whether they have reported smoking in the last 7 days, and if they've shown biological verification of absence by these 2 methods. We found that the rates were quite high. So small sample, but 80% success at 6 months, and at a very long-term follow-up at an average of 2.5 years or 30 months, found that held out to 60%. So this is like very early, and it's open label, and so all the caveats apply, but nonetheless, like, the question is whether this was worthy of follow-up. And by that, when you're looking at that question, I mean, these rates of quitting success just rival or are larger than anything ever published, at least in more, in research that's been published, for example, with either medications or different therapies. The best that's ever been published to my knowledge is using not just 1 but 2 medications for the first couple of months, and then continuing cognitive behavioral therapy on a regular basis for an entire year. So Sharon Hall did that work, and I think that their success rate was around 58% at the year follow-up. So this is certainly extremely promising. And so, yes, it was worthy of follow-up. Something else we found from that initial pilot was that smoking cessation success was related to the mystical type experiences measured on the session day. So again, that's kind of the 3rd example there of that finding holding up in terms of long-term positive effects across different populations. So now we're in the midst of our randomized comparative efficacy trial. This is a design that you would typically look at for a psychotherapy where blinding is not possible. And so it's open label, but people are randomized to receive either psilocybin or another treatment, the nicotine patch in this case, using the FDA label, standard label instructions for nicotine patch use. And I thought this was the next best step. Probably we would need a larger sample size for a double-blind study, and we didn't have the resources for it. And frankly, even though the double-blind is needed for the FDA pathway, I think scientifically, to see if something was there, I thought this was probably the most important lens to convince me in terms of whether we were still on the right path with this treatment, and whether there was promise to it. And we did scale down from 3 psilocybin sessions to 1 psilocybin sessions, mainly for experimental reasons, because we're doing fMRI before and after, not during this session, and it really kind of adds noise. We want to look at potential biological correlates of the long-term success, and if you have multiple sessions, that can muddy that up and add noise to it. But one of the nice things about it being open label is that we can take a snapshot at any point in time and tell you what the success is looking like. So we're mostly done with the trial. So out of the 80 folks, 44 folks have gotten to their 1-year follow-up. And so we're still looking for like 20 more people in the trial, but 44 people have gotten to the 1-year follow-up. And amongst those, the 22 in the patch in the psilocybin group are showing a 59% success rate, biologically confirmed. And in the patch group, that compares to 27%, which is actually very good for patch. I'm very proud of that. That's higher than you typically see 1 year with the patch, but nonetheless, right now, it's still nowhere near what we're seeing with psilocybin. So right now, it's still looking very promising. It's an ongoing trial, so that could definitely change. So major caveat there, but it's a very similar trajectory that my colleague Michael Bogenschutz has been seeing in his work that started at University of New Mexico. He's now at New York University, but he published this initial trial treating alcohol use disorder and showed a large reduction in drinking days and heavy drinking days. And he's now moved on and has recently completed a 100-person randomized trial with 100 people. And so we are anxiously awaiting his analysis and publication or public announcement of those results. So stay tuned for that. And my lab's published several survey studies. I was sort of intrigued even early on, like a decade ago, presenting even before it was done, the initial findings from the pilot study. Folks would come up to me sometimes at like, legit scientific meetings, sometimes at sort of psychedelic based meetings, but even at legit scientific meetings, folks would come up and say, sometimes pretty quietly, like, this happened to me, like they took like mushrooms or acid sometimes like 30, 40 years ago. And they said, I just stopped smoking. Or they'd have a story around another drug, like they stopped drinking and they didn't. And what our survey found was that this shows up out there. We can't speak to the baseline rate in the population out of the people that use psychedelics, but our goal was to categorize the landscape and describe these stories systematically. Typically, by and large, these people were not looking to treat their addiction. They were looking just to have fun. They're interested in the mental effects of these drugs. They've heard about them like a lot of people, but lo and behold, they had one of these aha moments that, like, why the hell am I smoking? Like, and they're done and they just quit, or they substantially reduce. Same thing with these other drugs. So we've published that now with smoking, tobacco, with alcohol, with opioids, with cocaine, with methamphetamine and cannabis. All of these, there are the stories of quitting and substantial reduction because of a psychedelic experience. And we've found through analyses that it's related to the we get larger reductions, more likely to quit than to reduce, with a stronger mystical type experience. And we also found out something interesting in terms of withdrawal symptoms, that people, it seems to be the more affective withdrawal symptoms people report to be substantially improved compared to other times when they've quit. The more somatic bodily withdrawal symptoms, folks will say the modal response is that it's about the same. So I think that may be a key to, the commonality across, treatment of depression, whether it's in cancer or in major depressive disorder, and the treatment of substance use disorders, like, affective processing may be a commonality. And we should be looking for those. Either we're dealing with snake oil, if it seems to be working for everything, we need to follow the data. It may not be working for all of the things we're examining right now, but if it holds up, we should be thinking about those common mechanisms like affective processing. One way to put it, that Michael Pollan credited me with this very non-scientific term in his book, the dope slap effect. Because I told him it seems like people are dope slapped out of their story. Like, it's just like there's this window of mental flexibility that's opened up, and people somehow let go of their models of organizing reality. So like they let go of their story about, oh, I'm just addicted, and I've tried to quit a million times, and I'm just a smoker, and like whatever, just don't worry about it. I can't change. Or it's depression, like I'm just a loser, I'm a failure, I'm never going to make it. All these, these thoughts and behaviors that all have this self-fulfilling prophecy and across these nominally distinct disorders. So I think something is going on like that. And I think about this as like addiction broadly defined, even if it's the addiction we see in depression, in terms of just being stuck in that mental rut of thinking about oneself in a certain way. And so, yeah, we're currently doing the smoking cessation work that's continuing. We're desperately trying to recruit for Alzheimer's. study. We're focusing on treatment of mood, so depression, much like our cancer work in early stage Alzheimer's patients, and also treatment of anorexia. We're recruiting for that now. We have a number of upcoming studies. We're going to be using psilocybin and studies to see if it can help treat opioid addiction and PTSD. I'm going to be principal investigator of those studies. So those are currently in process, either with the FDA or in the case of opioid addiction, or about to be submitted to the IRB in the case of PTSD. And then Fred Barrett's leading the study treating comorbid alcoholism with depression. Then doing some work continuing with this line of depression within chronic with medical illness, looking at mood in post-treatment Lyme disease, what's been called chronic Lyme disease syndrome. Also going to do some work with microdosing to see if there's anything there. People keep failing to find anything there, and it seems like it could be a whole lot of placebo. There might be something, a direct effect there, but it's yet to be shown in credible studies at this point. I'm also leading a study and looking at measures like burnout and professional engagement in creative professionals. So a study that sort of an interest that popped out of just kind of anecdotes from our other studies where people report this kind of re-engagement with meaningful aspects of their life. And then finally, I'm going to be leading a study with using LSD to treat chronic pain with an eye towards seeing if we can reduce or eliminate their opioid use in these chronic pain patients, picking up on like the very earliest work of LSD in cancer patients where the interest was actually in pain reduction, comparing it to opioids, and it was actually observed that there was this pain reduction that lasted a few weeks, which seemed to really be tapping into that psychological, very real component of pain. In terms of future direction, there's a whole lot to learn. There's literally hundreds of psychedelic compounds that Sasha Shulgin and Dave Nichols and others have cooked up, so we need to explore a wide variety of those. We need to like go through the DSM and basically anything that not everything, but a whole lot of these disorders seem like they involve this narrow behavioral repertoire I described. I think they're worthy candidates for investigation. Probably not everything's gonna work, but it's a lot of it's going to be worthy to explore. It's a good bet. And we need to understand psychedelic therapy. This is something the model hasn't changed since the 1950s, the late 1950s when it was first published, laying on the couch, introspecting, using the music. Does that work better than talking during the whole thing? I mean, early clinical report says that it did, but there's virtually no experimentation on the methods we use. And one little bit that we recently published was just sort of around the edges of that is simply, not experimentally manipulating the presence of music, but simply the type of music. It's going back to the 50s, the classic, what's typically been used is classical music. So we randomized in our smoking pilot for people to get either classical music or an alternative playlist based on overtone-based instruments, such as the gong, didgeridoo, singing bowls, this type of thing with a prominent harmonic overtone signature, very drony type instruments, including some of the classic Indian musical instruments such as the tambura, and everyone received both, but the order was randomized, and basically we found that we got a trend for even no statistically significant difference, but the trend was for the new thing to do better, both in terms of higher mystical experience and in terms of, we did get a selection of exposed to each of these playlists, and they got a choice on the third session. More people, a bit more than half, chose the overtone based playlist. And then based on that selection, we found that the people that chose that actually did a little bit better. Again, just a trend level, but in quitting smoking. So I think just in terms of that, of the new thing kind of doing better than this thing that's been used for like 80 years in, classical music, it kind of can encourage us to like, yeah, we need to do more experimentation, like, and we can probably shake things up a little bit without being too paranoid that the whole thing is going to fall apart. I mean, it seems to be pretty robust, these effects, and we can do a little experimentation around the exact way we're conducting the therapy. We need to do a whole lot to understand, these effects from a basic learning perspective, both behaviorally and biologically. So the evidence of neuroplasticity, different forms of neuroplasticity, is intriguing. It still hasn't been connected to the human therapeutic. These observations in non-humans hasn't been connected to the human therapeutic effects. There's a very, very good possibility there is a connection there, but we need to understand that and really, these are learning experiences. We need to look at them through that lens and see how we can tweak these methods to use what we know about learning to maximize that learning potential. And part of that, I think, is understanding this, what's been called integration period, after the effect, where people feel like they're in an afterglow. Oftentimes, again, we don't really know what that means. Maybe that's a subjective correlate of some of these neuroplastic effects, maybe not. But is there an increased a time after the sessions where people are more open to change, where there's increased behavioral plasticity? And if so, what can we better learn about how to leverage what we do in that time to maximize therapeutic learning? And then I think some other, just big picture, there's going to be a whole lot of challenges in this area for the future. So the ethics and challenges of the frameworks that we use. So something I want to keep drawing attention to is that we really need to move away from, I don't know, sort of a new agey vibe to this research and pseudo religious framework. Something I wrote about in this recent paper, and it's kind of many people view these experiences from a religious or a supernatural spiritual lens, but I think a very good case is made that that's not the heart of this. A forthcoming book by Chris Letheby, a philosopher that focuses on psychedelics, I think makes a really good case for this, that it's really a naturalistic understanding that explains these effects, and that the therapeutic effects and the beneficial effects can come with or without a layer, depending on the participant, a layer of a supernatural flair they can add on top of it. And I think it's going to be critical for us to realize in this field that it's not on us as scientists or clinicians to really speak to the metaphysical, to not deny it. We can't say that wasn't an experience of God, but we also can't validate it, to truly let the client steer the bus when it comes to those domains. And I think there's already too much of sort of stepping in and kind of playing priest or guru and by the part of the clinician or the scientist, and sort of steering these effects. So a whole lot to work. And as I also wrote in that commentary, I think there's a whole lot of opportunity to understand concepts associated with consciousness, but one of the things I've called for is more precision in our language. Do we mean phenomenal consciousness? I mean, explaining that is the so-called hard problem. And so maybe there's a chance we can leverage these substances to bear on the hard problem, which is explaining why experience exists, period. That's a tall order, so that might not be possible, but we could certainly leverage them more. Not much has been done yet in terms of understanding these other things that are called consciousness, self-awareness, and access consciousness as a couple of examples. And we need to do a lot of thought about, if they're approved, which it looks like they're in good trajectory, really how do we mainstream them as treatments, including how can we make it affordable, ensure that there's like equitable access to these treatments in this kind of very expensive treatment model. And I'll wrap it up there, but just kind of acknowledge just a whole lot of people. Just mention a few: Roland Griffiths, Mary Cosimano, Al Garcia, Fred Barrett, and philanthropic funding. Hefter Research Institute has kicked in a lot. Beckley Foundation. More recently, at a much higher level, or center level funding from the Cohen Foundation and from Tim Ferriss and Tim Ferriss's colleagues that he inspired to help donate to this center effort. So that's about it. And yeah, happy to discuss.
Awesome. Thanks so much, Matt. This is our silent clapping time.
Virtual.
Couple seconds of, yeah. Oh, we've got some videos on so you can see it. Real evidence. Biologically verified clapping.
Nice, nice.
So I got some questions, and feel free, anyone who has any more. Again, mindful of your time. I think it's getting late there, but just one for fun to start off. You mentioned we haven't really been modifying our protocol for psychedelic therapy since Al Hubbard or whoever in the 1950s. So let's just for fun. You have unlimited resources. You don't have to go through the IRB. You're a good. You want to be a scientist. You want to be rigorous. How would you design a psychedelic therapy trial? And let's say you can vary number of doses, dosage itself, drug of choice, environment, nature versus what's your intuition based on all that you've seen and your curiosity? Where would you go?
Oh, I love that question. Oh, wow. I've never quite gotten that's like my favorite question. Yeah, so on the Caribbean island where there's no like international drug law, and I'll be ethical, but like there's still no IRB to do, and there's unlimited funding. Okay, this is fun. So it's not all going to fit into one experiment, but there's going to be multiple experiments. But gosh, yeah. So one kind of big thing is like nature. Everyone says like these experiences are better in nature. Okay, like let's test it. That's easy. People are in a natural, and you could do multiple natural environments. A forested, kind of nice, wooded hiking area, or maybe it's maybe another condition is on the beach of your Caribbean island, and maybe another condition is in your, something like what we're doing. You go into the cottage of the island, and so you test to see if there's a difference. And it may be that you get different types of, depending on what you're looking at, you could get, there's maybe not a black or white answer. I mean, maybe you shape the experience in different ways. I mean, so thinking of the mystical experience, one of the nuances is that the unity construct is actually composed of a sense of both internal and external unity. So one aspect is feeling a sense of oneness within yourself, but another is feeling one with the external environment. Perhaps you maximize external unity if you're in a natural, beautiful area. Also need to look at, the presence of kind of talk therapy during it. It was the clinical wisdom that you had better results when the clinician just shut up and let the magic happen in the early days. Leo Zeff, I'd recommend people read the interview book with him called The Secret Chief, where he describes this. But hey, if that's true, let's see it under experimental results. Like, could we apply models like the old, what was called psycholytic therapy, typically done with more of a lower dose, but you could do it at the high dose, or at any dose, have people talk through the experience, to really, with the gifted therapist, to leverage to get them to not kind of drift off into the bizarre, but kind of like keep focusing on their internal psychological struggles and processes, or whatever the therapeutic issue is. And gosh, there's all kinds of things you can study with if there was the unlimited funds. I mean, I think like on the music dimension, like live music is something that needs to be looked at, like that. With that novel playlist I have, one of the nice things, it's like it doesn't take much to learn how to play a gong. We could actually like test that. There's like the presence of live harmonics. If anyone's ever experienced some of these things, like a kind of a sound ceremony, you'd actually feel one of the the harmonics of this instrument kind of vibrating through your body. It's pretty cool. And then combinations with different therapies. Gosh, I think of like float tanks, and part of this is like getting back to like the stuff John Lilly was doing more with ketamine but people today describe just incredible results combining some of these psychedelics with these other methods, like, sensory isolation, like in a float tank. So I don't know, that's just a few of my, thoughts. And then you get into like combining drugs, like, design studies where it's like, okay, set and setting, people have for years have done things like, okay, start off with MDMA and then, administer. And this is where you get past the IRB and the FDA, because they'd want some more data before we could do that probably. But, giving MDMA is a heck of a way to establish a positive set and setting, a couple hours before you administer the psilocybin. And, even though it sounds kind of weird these days and the drug has a bad, reputation, but back in the old days, Myron Stolaroff said his first exposure to LSD was after, and it was actually Al Hubbard who did this to him, who you mentioned, Johnny Appleseed of LSD. He gave him a good dose of mephedrine before, which is another term for methamphetamine. It's a heck of, basically the same as Adderall or, D-amphetamine, but it's a heck of a way to put someone in a positive mood. And they were doing things like, if you had an anxious patient, like give them a sedative along with the LSD in the older research. And some of the psychodynamic folks will say, oh, that's horrible, because then you're suppressing, you want the conflict. And like, maybe, we don't know. It's an empirical question. Like, would it be better if we gave people a little bit of Xanax during I don't know. That's an experiment right there. If the results show it's not as good, then yeah, there you go. But maybe, and maybe it depends on the person. So I could go on and on, but like, those are some dream studies I'd love to do.
Yeah, I mean, maybe I should have made that a more fair question and just given, say, 6 variables, and then you change them. But what I'm hearing is we'll need $100 million. We'll have,
right,
LSD and MDMA in the forest versus, ketamine in the isolation tank with overtones versus, methamphetamine and Xanax assisted psychotherapy with psilocybin in the Johns Hopkins couch. So
I like that. You could wrap it all in just one study. I mean, there'd be some confounds, but it would be fun.
Plenty more questions, and we'll try to keep this limited. One I wanted to point out is, you mentioned for practical reasons, you had to go from your 15-person pilot trial with smoking cessation to the more phase 2 type, randomizing to patch versus psilocybin. You went down from 3 sessions to 1 session, and also even still though, I think there's you can see in that graph from 3 months to 6 months to 12 months, you see this increasing abstinence rate. And so I was just curious to get your take on, you see this in the MDMA data where it's like 54%
Yeah.
out of PTSD, have no PTSD right after, but then a year later, it's like 2/3. So it's a similar effect to see this like over time increase. So I was curious what you make of that.
Yeah, and so I've talked with Peter Hendricks, who's doing work with cocaine, psilocybin to treat cocaine at University of Alabama, Birmingham. He's seeing a similar thing, and we've talked about this. This is like weird. Like, you don't see that typically with addiction, and I'm less familiar with PTSD, but I'm pretty sure you don't see that either. It's like you don't, like most treatments, you don't see this sort of incubation effect. Certainly not from a medication. And I think there's some evidence. Yeah, I do know that there is some evidence. Sometimes you see this with things like CBT. But I think that kind of points to something. I recently wrote a paper with Sandeep Nayak about this. This is really more, and it's other people have said this in different ways. This is more like psychotherapy than a traditional. It's the biological effects are ones that allow, biologically facilitate therapeutic process, these psychological processes. And I think that's the reason why, like, people actually learn something. They start living their life in a different way that has a feed forward effect. And it's like, it's freaky with addiction. It's like, it's really cool. Like you just don't see that. Like why would point prevalence abstinence get better over time? Like
It makes you,
I
yeah.
point, like there are a number of cases where people that have slipped in our study and they do return to this. I think of them just this kind of like this great gravity to the psychedelic experience that kind of
So
like
the
holds
one,
things together. Yeah.
right, the one treatment in psychiatry that looks like that for depression is vagal nerve stimulation. You see the exact
Oh yeah.
shape over a year where it continues to maximize. Yeah, ask Scott about it because he knows a huge amount. He's doing a new trial actually. So that's the only thing I know of in psychiatry where you see that. And the vagal nerve stimulation is ongoing, but it's not a drug.
Okay. And I
Maybe
wonder,
add,
so, and
oh,
why
go
would
ahead.
that continue? I wonder why, is that known why that continues to?
Ask Scott. I don't think so, but he'll have some ideas about it because he's been working in that quadrant for at least, I don't know, 10 years.
Huh.
And he's launching a new trial in it as well.
Oh, cool.
It makes me wonder, Matt, when you see that increase in effect, when the primary outcome should be. If you're seeing these massive effects, usually it's the opposite, right? With ketamine, you see the effect peak at day 1 and it's off by day 7. So you measure at 2 weeks, you don't see an effect. Versus, maybe for smoking cessation, it's more important to measure at say 6 months than it is at 2 weeks. Anyway, just a thought, but
Right. And I think, that's what counts with like, with the use of a substance. It's like,
right.
It's the long game. It's like, it's
right.
not a week's worth of cigarettes that's going to kill you. It's like
right.
20 years of cigarettes that'll kill
right.
you. And yeah. And one of the things it highlights for me, and the data look very good both ways. And I showed you point prevalence, but sometimes you can also look in terms of continuous abstinence, and there's kind of a meaning if you ever have one puff on a cigarette, you're a failure and you never have a chance to go back, even if, and there's modifications of that, like where you get a 2-week grace period. It's called prolonged abstinence. But if you slipped in, it's fine. You could still be a long-term cigarette. But it's just the whole idea, like, really, someone that has a cigarette a month in and then catches themselves and doesn't smoke again, and they're a failure. Like,
right.
And I think that's part of where the action, I want to dig in more of the data to see if we can learn more about this. But I think that's one of the reasons why we're getting this increase in efficacy rates, because like you might get the same amount of like, yeah, people all like hit their weak points, and like, yeah, you slip, you had a bad day and you have a cigarette, but people seem to be catching themselves more. And like, that's what's important. It's like, no, like whatever, I screwed up and had a cigarette. Who gives it? Like, I'm not a smoker. I'm not going to continue it. And like, yeah,
that almost seems like one of an important thing to measure, right? Is of those who have had the psilocybin treatment, of those then in that group, the subgroup who slip and then have a cigarette, who then goes back to being abstinent. In other words, measure resilience as a function of psilocybin treatment. Before we spin out of control with this though, because I feel like this could go on for hours. I do want to, Raphael had an addition to the dream question. I think he wanted to, and this will be the last question on the dreaming up a study or whatever it may be, and then we'll ask some others. Go ahead, Raphael.
Yeah, thank you. Hi, I'm Raphael Playo. You mentioned dream research, but what about actual dream research? In the concept of lucid dreaming, the fMRI data describes it as a hybrid form of consciousness. And young people who've had the experience of lucid dreaming often describe it in mystical effects on their life. So just pure ignorance on my part. Any thoughts on how this interacts with psychedelics, any overlaps in that area with lucid dreaming? Oh, by the way, there's data now that lucid dreaming has been shown to increase creativity in people with narcolepsy. So there's emerging data in the sleep world on this area, but nothing on the psychedelic issues with it. So just curious, it seems like a natural overlap.
Yeah, I wish I had more to say, like scientifically based, other than like, I think it would be a huge opportunity to combine these methods now that there are methods that can help to occasion lucid dreaming in people, like I mentioned earlier, by combining with other treatment, and we've done some work in like looking at the psychedelic experience and meditation and additive effects, but in a similar spirit, I think there's really interesting potential to look at that. My just personal subjective sense is that there's something very similar there. I mean, I've had lucid dreams, and they're just, what you say makes sense to me. They're incredibly creative, and it seems like they could be therapeutic. I mean, they seem very psychedelic, like, broadly speaking. So yeah. And there, another thing I'll mention about that, there are reports of people, and you see this across different drugs, of just purely anecdotal, that people report using a psychedelic in their dream, even like smoking DMT, and people with that experience, and say it's really like that. Like when they smoke DMT or take acid in their dreams, that they really are having that type of experience. And this is from people who have had that type of experience. So can you maybe if you kind of establish one of these drug effects, maybe then you could train people to revisit that on a once a week or maybe every night, who knows, basis, without taking the drug, through the right method, to revisit that state if it's helpful.
Thank you. All right. Thank you very much.
Mm-hmm.
I feel like we're adding arms to this trial. Now we've got a psychedelic induced lucid dreaming arm, a vagal nerve stimulator arm. Just fantastic. Couple questions about this idea of mystical experience. And I know there's a lot of excitement about it, and I think your stance on it is more sober, say, and not to get too myopically focused on this or that thing as the mediating factor. And Boris, feel free to jump in, and David as well with your particular questions. There's this debate right now of, is the mystical experience, is the subjective experience of psychedelics necessary for their therapeutic effects? For two-part question, they're kind of different, I guess. Boris is curious, and feel free to hop in. Is the mystical experience sufficient for a therapeutic effect? And that could mean mystical experience from a non-drug, any non-drug route, like say breathwork or whatever. So can a mystical experience, independent of drug, be sufficient for a therapeutic outcome? And the second part, I think, asks a different question: is there any relationship with baseline mystical experiences in your participants with therapeutic outcomes? Which I think, in other words, is there any relationship with a person having had mystical experiences before and then having therapeutic outcome in the psilocybin trials?
Yeah. So for the non-psychedelic methods, I will say I do have an approved IRB protocol for holotropic style breath work, seeing if we could treat PTSD patients with it. And then COVID happened, and I tell you what, that's the most COVID unfriendly intervention you could possibly ask for. Get a bunch of people in the same room and purposefully start breathing heavy on each other. You have this facilitator sitting over the breather. So anyway, so that study is on hold, but yeah, I mean, that's kind of based on this idea that if there's reports of these very psychedelic type experiences from that method of controlled heavy breathing. And so, hey, maybe there's a therapeutic effect there. So and then I know there's any number of ways to test. I know Boris has thought very, very deeply about this, to test whether there's, to separate, to test this, whether the experience is necessary. My best guess is, and I'm driven by the data, so I want the studies, but the best guess is that for the long term, for this kind of therapeutic model that we've been working with, where you have 1, 2, or 3 sessions, and then you see improvements in behavior 6 months, a year later, I think you're probably going to need the experience, because that's the source of people learn lessons from that. like that's a life experience. It's analogous to a life experience they learn from and changes their behavior. I think there's probably multiple things going, and I bet that, you know, there is going to be therapeutic efficacy to some of the non-psychedelic analogs, and perhaps that are inducing neuroplasticity, and perhaps that's a similar thing to microdosing. If some of the studies eventually show that there is any like therapeutic effect, if there's something there, I think probably what's happening is more of a general plasticity, but just like increasing plasticity is not like that could be a bad thing. And that totally depends. And so the experience, particularly in a clinical, like intentional therapeutic setting, provides a direction to that plasticity. But if you just open plasticity for a few days, which is probably what you'd get from if you didn't have the experience, if you just had a drug effect, that, you know, it would probably depend on what you did during that. So maybe if you had a psychedelic without an experience, maybe it could be helpful in the long term if you leveraged like intense learning trials of some type during that period. But I think in full psychedelic therapy, you get a double whammy, and it's like the experience is serving that role of providing direction that can, if there's this increased plasticity, like there is something to learn, and then that, you know, to it, you know, so those are just my speculations though.
Yeah.
Boris, do you have any like comment on that? Like you could probably.
Thanks for the shout out, Matt. I have lots of comments on that will probably extend long past our deadline. I'll just say that there's a nice little point counterpoint between David Olson. This is, I think, in the I forget where it's published, but if you look up Olson, I think Yaden is the counterpoint.
Yeah, David Yaden and Roland Griffiths were, yeah.
So obviously my favorite experiment is try and, you know, test this with general anesthesia, but, you know, when all you have is a hammer. Anyway, I'll let others ask you some more questions.
Mm-hmm.
If I might, I wanted to amplify that. Oh, sorry. I wanted to amplify that question that I asked about, because it seems like, you know, in clinical practice, oftentimes we'll hear a, you know, patient say, I was an alcoholic and then I went to AA and then I prayed and then God moved me. I had this experience and now I don't want alcohol anymore ever. And that was it. And it just sort of in a moment, sort of these naturalistic experiences. And, you know, and also sort of, you know, protectiveness of religious background in general, or spiritual experiences in general. I wonder, did you gather baseline data on your participants, and is that like baseline experience of having these experiences, was that for people who were basically starved of them? Was it more effective if you've been starved of them, or is there any relationship to those background experiences?
Yeah, so we have seen that and this has been this kind of relates to previous research, but that having had more of a lifetime of mystical experience, that people are more likely or have to have stronger mystical experiences with psilocybin. So I think, you know, it seems like there's probably some trait-like aspect to this. Some people are inclined towards it, but it's certainly not a black and white. I think one of the nice things about these psychedelic drugs is that they're such sledgehammers that it's astonishing that you can get these experiences, and the last people that, you know, or, you know, not everybody, but in people that aren't high in that trait, you know, like the people that could like meditate for 1,000 years and they'll just tell you, I'm just seeing nothing. What do you want me to, you know, this is stupid, you know, like they're just like not open at all. You just hit them with a big dose of a psychedelic and like, you know, you're more likely to get some openness to these, you know, whatever you want to call them, you know, transcendental type effects. So, so yeah, even if there's a trait-like aspect and you're more likely to get in a certain type, I think it doesn't mean it should be limited to those types. I think it can be incredibly useful. Even if in those other people, even if their ultimate experience may not be as strong as the other folks, just that you're having anything like that experience, and those folks is really important.
Yeah, thanks for I think I butchered your question, David, but thanks for clarifying. And thanks, Matt. Tried to squeeze two questions into one, wasn't great. I know it's super late for you, Matt. Maybe just one more. I think Raquel, I see your hand is raised. I don't know if you want to chime in and follow up with that.
Thank you. Yeah, I'm a psychologist in the Department of Psychiatry, and I did some work in substance use clinics a few years ago. And one of the things I think a lot of the psychologists ran up against was pushback from some of the patients who were like, well, if you've never had substance use, like you can't really understand. And so without disclosing anything personal that you don't want to, I was just wondering if we're thinking about getting psychologists trained to do this type of therapeutic work with patients. Do you anticipate that they will ask the therapist if we've had these, if we've had experience ourselves with these drugs? And do you think it would be worth it to do that? Or just what are your thoughts on that in general?
Yeah, that's the big question. That's always like, one, I think it's important to note with the substance abuse work that substance use disorder, analogy that you're bringing up there. The research has not suggested that there's any truth to that. That like
Right.
that you get better results if you in fact have, as a therapist, a personal history of overcoming addiction. So it's a tough thing. I think if there's a correlation there, it's not like a perfect one and it's not a black and white relationship. In other words, I have no doubt that you can have gifted therapists that can be psychedelic guides who have never had a psychedelic experience. Are you more likely to have more effective guides if they have had psychedelic experiences? I guess is probably yeah. Another point to make is that you certainly don't, anyone who really knows and has hung around a lot of people that have used a lot of psychedelics, like I think everyone gets this. It's clearly not like just having taken a psychedelic is not sufficient. Like I think most people that know a number of psychedelic users can think of plenty of examples of people that have taken lots of psychedelics that should come nowhere near the role of a therapist. So, it is more black and white than some people would that some people would describe. And another thing is that, the legality, of course, makes it like super difficult to talk about these things and to, now like the MAPS group, and I wrote a letter of support for this when they tried to get approval, was like they have a protocol where their therapists can receive MDMA training under a study, which I think is great in providing that legal framework. It's not required, and I'm glad that they're on the same page as me. Like you could never require that. I mean, not everyone would pass our screening procedures. I mean, you might have a heart condition as a therapist, and like all of a sudden you're not allowed to be a therapist in this area because you don't meet the criteria. I mean, that doesn't make sense. So, I think, one way to, is that people can have experiences in so-called altered states of consciousness with different methods like breath work or other, techniques. And yeah, who knows if the therapeutic, if the legal framework is there, for them to have an experience, and then yeah, if the person, if it's right for them, I think, there's a decent chance for some people that it is going to improve their empathy. But like, I'll say one more thing. There's lots of things to say about it. You just brought up it's such a huge topic that, in the old days, you could find like just examples of this horrific research of people getting loaded up with LSD with people that had no clue with no empathy of what's going on. The best description is in Electric Kool-Aid Acid Test by Wolf, about Ken Kesey's first experience with LSD, which might have been at Stanford. And he was, and it's just like 5 pages of just description of the most intense LSD experience imaginable. And his mind, and this guy's already clearly a genius. He had already written 1 or 2 highly successful books, and his just mind is just going to the races, and just like revelation upon revelation. And this checked out, doctor in a white coat is just like checking his his ability to replicate a time, like tell me when 1 minute has passed, and just it's totally clueless to like the whole, not that he would know exactly what's going on in the guy's mind, but just the idea that like, yeah, I might be occasioning the most, or one of the most intense personal experiences person has ever had, and just no appreciation for that. So just, whether someone's had personal experience or not, I think just that the more important thing is just that someone has a deep empathy for the power of these agents to potentially do that. And also the humility. There's a risk in like assuming, if someone says I've taken psychedelics 500 times and well, you're not necessarily having this like the result of the grandmother has terminal cancer who's on the couch right now. And even if they're the same demographic as you and everything, you still haven't had that person's experiences. There's a danger in assuming, on this other side of assuming that your experience gives you, some sort of in-depth insight. So it's a very nuanced area with, I think those are all of my standard, kind of thoughts about it. You can tell I've thought about this for years, and it's just like, it's a great question, a lot to chew on.
I'm well aware that there's many questions that didn't get asked, and I know there's a couple people with their hands raised, but I think we should probably be respectful. I think it's going up on 11 p.m. on a school night here at Tuesday night at 11 p.m. So you've been super generous. Stayed with us a little late, Matt. So
well, it's my pleasure. I was the one that was late on you, so my apologies for that, and happy to hang out with you.
Yeah, we got an excellent fourth quarter comeback and a really nice talk. I'll give you the final. First of all, thank you so much. Thanks everyone for coming and sticking around. And then I'll leave it to you, Matt, if there's any final words for people in the audience and people interested in psychedelic science. Any things you want to say to the audience.
Oh, it's in terms of psychedelic science, I just want to say this is still totally entry level. Like, I've been in it for 17 years, but I think we're going to look back on it and see, 2021 as still like early days, so, jump into it in the right way if you're interested, whether you're, established investigator or a student. And I can tell you, like, from my experience, it's not a career killer. I mean, you could probably do it in a way that would be if you're dumb, but like if you're, it's been very good to me, just at the, in terms of academics and going through the ranks at Johns Hopkins. It certainly hasn't been an obstacle. It's helped land some of those criteria that you need to move through the ranks to full professor, like international talks and not just papers, but highly cited papers, that type of thing. So yeah, it's a huge opportunity if you're interested in this stuff. And there's just like, these questions just reveal, like, there's just mountains of there is so much that needs to be researched that is like 100 times bigger than the number of investigators that are currently in the field right now. So it's just a huge growth opportunity. So jump into psychedelic research if you're inclined to. That's my pitch.
Awesome. Well, thanks so much, Matt. Really appreciate it.
My
Thanks
pleasure.
again, everyone.
All right. Thank you.
Take care. Good night.
You too.
Thank you.